Hey everyone, welcome to Resiliency Radio, your go-to podcast for the most cutting-edge insights in integrative and functional medicine. I'm your host, Dr. Jill, and with each episode, we dive into the heart of healing and personal transformation. Join us each week as we interview renowned world experts, medical leaders, thought leaders, and all kinds of inspirational speakers. I know each week I learn right along with you, and I hope if you enjoy this show, you will hit the subscribe buttons. Statistics tell us that about 80% of people watch without ever subscribing, and I just want to say if you like the show, if you want to hear more, I would love to see you click that subscribe button and then click the bell so that you can be notified of each new episode. We release a new one every single week. Today, I am super excited to introduce my friend and brilliant colleague, Dr. Shelese Pratt. She specializes in individualized integrative medicine, focusing on complex metabolic conditions. Using functional medicine, methylation, and physiology, she helps patients identify root cause of their symptoms with a personalized approach. Her practice includes nutrition, botanicals, homeopathy, hydrotherapy, and environmental medicine. You're going to find out as you listen to Dr. Pratt, who's been on the show before, and she's been a guest favorite. You're going to find her brilliance and her ability to go to the deep heart of things today as we talk about menopause. You're going to hear a little bit about where this conversation started in a coffee shop as our friendship was talking through the complexities of menopause and hormone replacement. And we're going to dive deep into the things that you may not have been thinking about if you are on hormone replacement, if you're about to get on hormone replacement, or if you're a man who's hitting andropause and having symptoms of low testosterone. All of this matters. So join me as I dive deep today with Dr. Pratt. Shelese, not only are you a brilliant, brilliant clinician, someone I've respected for years and years and years, but you are one of my dearest and best friends. And so this is actually one of the biggest honors in the world to get to talk to you. And the topic today, we have the title of Mastering Menopause, Essential Tips for Navigating Change. This started in a coffee shop several months ago, and I'll let you jump in, but I'll just tell the backstory from my perspective. You and I love to have coffee and pray together and just talk about life and have the support for one another, but we like to actually talk about cases and talk about complex metabolic problems and things we're seeing in clinic. And I know I've learned so much from sharing in those coffee sessions with you. And today, people are going to get a glimpse into coffee with Dr. Pratt and Dr. Jill. So I'm super excited to share you with the world. And we've had other episodes, but this one particularly, we both came to this conclusion. Right now, if you're out there and you're going through menopause, thank God there's so much more information out there on menopause and those suffering from those symptoms, because for a long time, conventional medicine ignored it. But what you and I were talking about is there's so much more to the picture. And there's so many things that women need to be aware of as they think about hormone replacement and all the things that go into this. And I have a particular interest and passion because I'm a survivor of breast cancer. So first of all, I want to jump into just how did you get into medicine, and then we'll go into our topic. But I kind of want to frame that because I know this is going to be a really, really important topic. If you're out there and you have a friend, a sister, a mother, a daughter, anyone in the world you love that's a woman that's going through menopause, perimenopause, save this episode, share this episode. This information you are not going to find everywhere else, and it might be the might be the information that just changes your life. So, Dr. Pratt, before we jump into that, tell us a little about your journey into naturopathic medicine and how did you get to where you're at now with the expertise?
Sure. Well, thank you so much for having me. As always, I love to share perspective and context from a larger metabolic perspective. So, and I've spent many, many years fine-tuning my skill at really being a mitochondrial expert and through the context of metabolic health. And metabolic health means a lot more than like weight management or simply your A1C and your uric acid and your glucose levels. So we're going to dive into all of the complexity and some common sense ways to also approach this. But getting back to your question, how did I get into becoming a naturopathic doctor? Well, back when I was 19 years old, I had severe asthma to the point where literally climbing the stairs in Boulder, Colorado, I was in undergrad and I was sick all the time. And every time I got sick, it triggered my asthma. So I was put on several rounds of antibiotics and prednisone in order to manage my symptoms. And I got really frustrated at one point, and I bought Andrew Weil's book, Spontaneous Healing. And his work in that book changed my life forever. It showed me in 19, what was it, 90, whatever, I guess it was 93 or 94. Um, it opened a door to another way of practicing medicine, another way of approaching my complex medical condition that, not being able to breathe as a 19-year-old was pretty limiting in such a wonderful, beautiful place that you constantly wanted to be on hiking trails and skiing and at the time rollerblading and all the wonderful things, activity things that we wanted to do. And I was being held back. I would get sick all the time. And so I changed my diet from his book. I started learning about all the different forms of medicine that I could go into because Andrew Weil kind of expressed like you could go see a DO, you could go see a naturopathic doctor. And I was like, who are these naturopathic doctors? And the more I learned about it, the more that Hippocratic oath, that form of medicine really called to me because it's what healed me of asthma. So I haven't had an asthma attack since I was 24 years old. And it was through diet, it was through a mindset change, how I talk to myself, nutrient deficiencies. I did the work. And when I went to naturopathic medical school, I truly fell in love with the breadth of how we learned medicine through a nutritional, a botanical, a less invasive way to handle complex medical scenarios. And for me, what was really frustrating is after I had all that asthma, I then got shingles and I was in a doctor's office and I asked the doctor, how did I get shingles? And she said, do you have a computer? And I said, how did my computer give me shingles? And she laughed at me and said, as she walked out the door, look it up. And it was at that moment I decided to be a doctor because I wanted to help people.
Yeah.
And I wanted people never, ever, ever to have that experience if they worked with somebody that cared for them.
Wow.
So it was a combination of, physician heal thyself,
Yeah.
as well as an experience of, wow, somebody really didn't show up and answer any of my questions about how I got to where I got, which all the prednisone I was on for those years really wrecked my immune system. All the antibiotic use wrecked my microbiome. So I needed to rebuild that in order not to get shingles again. And again, that would have been a 2-second conversation if somebody would have cared to have it. And so, but it was God's way of saying, no, this is your chance, Shelese. This is where you're going to go. You're going to go and help lots and lots of people in the future and help explain how they got to where they got.
Yes, and thank goodness, because not only are you my dear friend and someone I deeply respect, but you are one of those top 1%ers that really does go deep and look at root cause at a whole nother level. Your ability to go into the genetics, the metabolomics, and all the stuff we're going to talk about today, which is why we sat at a coffee shop a few months ago and said, this hormone story has more to it, right? Like, why don't you frame where that conversation started and then kind of frame our conversation today of why we need to talk about more than just, now, just to be clear, we're both advocates of hormone replacement. This is not saying that's not appropriate. I'm on hormones and both of us have experienced this. However, there's a bigger story. And why don't you just frame that for us?
Well, I believe everything should be put in context. And so when I see or I hear from many, many of my middle-aged patients coming to me saying, I keep hearing on Instagram, I keep hearing on TikTok, I keep hearing from all these social media venues that hormones, 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 everybody should be on hormones. And then I have to have the conversation of, yes, and there's a context to put those in. So, I'm going to go through some slides today and show you kind of my thought process on what might be missing from a lot of doctors when they're treating the symptoms of perimenopause or menopause or andropause, in men.
Yeah.
There's certain things that we need to, again, remember the roots of individualized medicine. And this might be new to doctors that are treating with HRT that have not thought about it in terms of individualized medicine, but I'm going to make a case for
Yeah.
how important that is, especially when we know that there are risk factors involved of anything we put in our body,
Yeah.
anything. So I think, Jill, I think both you and I would say not everybody needs the same diet.
Mhm.
Not everybody is going to benefit from the same supplements. You know, there are some people that can't take methylfolate. There are some people that can't take fish oil. There are some people, and these are things that, again, hormones are going to be the same conversation. There's going to be people that, yes, this might be a great opportunity to minimize symptoms as they move through this change. And you might be able to also offset cognitive decline and help with reducing cardiovascular issues in the future. And there are benefits, but there are risks, and nobody's talking about that. And I am going to put into context, a larger context, maybe a little bit more complexity of what goes into really understanding how to meet this person and treat them on an individualized basis.
Love it. Couldn't be more excited. And feel free at any point you can just share. I know you put some slides together. I think people are really,
Mhm.
really going to. And what we'll try to do if you're listening in your car or somewhere where you don't have access, first of all, you can watch this on YouTube. This might be the one that you really do want to watch on YouTube so you can see the slides. But we'll just kind of articulate what we're seeing on the slides as well. So don't feel like you're missing everything if you're listening on audio.
So, Jill, pipe in. We both are strong, staunch believers in individualized medicine, where we want to know your history. We want to know all the facets that make you who you are, from the way you think, from the experiences you've had, from the environmental impacts that you might have had, whether it's been infections in the past or lots of antibiotic use or exposure to certain toxins. We want to know about your circadian rhythm. We want to know about what nutrients you've taken, what you haven't taken, what kind of diet you've been on, the challenges you've had with different practitioners and different programs that you've been on in the past. This helps us understand a larger picture of who you are, what individualizes you. What when you come into my office or Dr. Carnahan's office, we see you as your own unique, beautiful flower, right? That needs what nutrients and what sunlight and what do we give you to grow and bloom in whatever phase of life that you're in, right? And wherever you're at, you need different things, and at different times of your life you need different things. So we take into account all of your history. We love to know everything about you, actually. And then we do a deep dive into labs for like looking at metabolics, looking at we're going to get into some of the labs that I like to look at. I'm particularly really invested in also looking at genes. What genes do you have and how are they expressing? And many of you may or may not know, you can actually run tests to tell me how are these metabolic pathways moving. So when we talk about genes, I think a lot of people need to remember these are enzymes in the body.
Mhm.
These aren't just things that you have.
Yes.
They actually are part of an amazing physiological process in your body, and they relate to enzymes, and whether those enzymes go really fast or really slow, whether you're missing the cofactors to make those genes go, we're going to get into a little bit of that. So, um, and so, yeah, we take into all aspects into a treatment protocol, whether that's incorporating hormones or not. And as Jill really does a great job at helping you also understand is mindset. A mindset is really, really important at whatever phase of life, but especially at if we're going to talk about this middle age transition of your hormones, I think mindset is a big piece too. So these things all make up uh, who you are and who and where your mitochondria have traveled with you,
Yeah.
which is your cells powerhouse, right? That's how you make energy. It's why we breathe oxygen, is to fire up these mitochondria and they make beautiful energy for us. And some of us are damaging or harming our mitochondria, and we didn't even know it. And we're going to talk about some ways that we can optimize our mitochondria if we're looking through this individualized lens. What do you think, Jill? Do you have anything to add to that?
I just couldn't agree more because it's really the person that you're giving the hormones to that you want to know, and any great physician is going to just get those details and make sure that they know because the risk is there depending on what you have in the background, and it's not everybody has the same. There's no one size fits all, is what you're saying.
Exactly. Exactly. What's in your past matters. When you were cycling, let's say you're a woman and you are thinking, let's say you're 45 and you're thinking about going on hormone replacement, some big flags for doctors, those doctors out there. And if you haven't had these conversations with your doctors, I strongly encourage you to ask your doctors about what we're talking about today. So if you had PCOS or endometriosis, you already had a relationship with hormones that was challenged a little bit. And there are certain metabolic factors that we really want in alignment. And we have to be careful about hormone replacement when you've had PCOS, even if you're through menopause,
Mhm.
just because they are risk factors for metabolic diseases that you don't want to trip into. So, infertility or fertility treatments, oral birth control or other birth control uses. We want to know your total history with hormones before we prescribe hormones, or talk about dosage or any of this. We want to know, did you have maybe some estrogen? We call it dominance, but it's a ratio between estrogen and progesterone. We want to know, did you have fibroids, which that means estrogen was a little too loud in your body at a time, or fibrocystic breasts, or heavy periods, or breast tenderness, or hot flashes when you were cycling. These are all signs that your hormones were not being balanced and they were irritating some tissues in your body. And so if you have this tendency towards estrogen dominance or this out of ratio from estrogen to progesterone, we need to know that because again, that set you up metabolically that we need to look for some things on the other side of menopause or even in perimenopause. If you have a family history of cancer or like a lot of hormonal symptoms, like let's say you have Hashimoto's, you have thyroid issues, these are all more consideration to put into context certain risks with using hormones. And then, of course, many women don't know this. If you have migraines, you might have more clotting risk. If you have a history of stroke in your family, you could have more clotting risk with using any type of hormone. Anything you want to add, Jill, before I move on?
No, I think a lot of women have these things and then they get to menopause and have symptoms and they're just thinking about that one moment in time when the whole history. And birth control pills, it's interesting. There's a lot higher risk of cancer with oral contraceptive than many of the other non-synthetic hormones. And so it's sad to me that in the public, they're given out like candy. And there's so much controversy over bioidentical hormones. And there's a real difference in synthetic versus bioidentical and the risk that it involved with the receptors.
So to speak to that, oral birth control use for years of their life, which many women have been on, thyroid disease, specifically Hashimoto's or hypothyroidism, high cadmium, a lot of chest x-rays as a child before the age of 16. We're increasing with each one of these things the incidence of breast cancer. And they're saying now that breast cancer is going to be 1 in 3 or 1 in 4 women. So this is why there's a larger context. If we're going to throw around hormones, what are we doing if we're not looking at where we've been?
Yeah, couldn't agree more.
So there is a lot of tests that both Dr. Carnahan and I run.
Yeah. Love
in
it.
general, because we look under the hood. We really want to know what's going on metabolically for you because all of these things are interrelated. And like I said, the risk factors that we just described, there's many different risk factors for all different kinds of cancer. There's all different risk factors for different kinds of flares of autoimmune. I mean, the list goes on and on about these chronic health conditions. And what we want to do is we want to promote health in the context of knowing all the details. So I like to run a CBC. I like to know what your immune system is doing, especially in the last couple of years because white blood cells, I don't know if you see this, Jill, but there are certain people in my practice that their white blood cells are lower than they used to be.
Yeah,
Are you seeing that as well?
absolutely.
Um, so a good comprehensive blood um, count is super helpful. It also helps on that comprehensive blood cell count. We're going to have an MCV, a mean corpuscular volume. That means the size of your red blood cells, which tells me a little bit about your need for folate and B12. So it gives me a little peek into, are you not getting enough B12 into your cell to shrink it down to make it the right size to carry oxygen efficiently? So I mean, this is just a basic test that most people run, but when we look at it in the context of a functional range, that white blood cell should be at 5. That CMV should be probably under 90, but above like 80, would you say, Jill? Because we don't want the cells too small and we don't want them too big. We want them just right, the Goldilocks principle.
Exactly.
And so another thing that's on the CBC is your lymphocyte to neutrophil or your neutrophil to lymphocyte ratio. And that's good to watch. That's just telling us like, okay, have you been fighting bacteria? Have you been fighting viruses? If you have, are you depleted? Are you a little depleted in one or the other? It's also kind of an idea about, how robust and how balanced is your immune system because we want those neutrophils to lymphocytes to be about 2 to 1. So it's again, I'm not trying to get mired in the details, but it's showing patterns. And I'd say, Dr. Carnahan, both you and I, and what we love about each other is we talk about patterns all the time.
Yes.
And if we're seeing certain patterns, it brings up a flag for us.
Mhm.
So, and it lets us know how these metabolic patterns are happening and these metabolic pathways are happening in the body. So that's just some of the things. You can also look at a monocyte. And I don't know, Jill, do you ever use the monocyte to basically think about what's going on in the GI for you? When
Yeah.
it's at 12, 14, your monocytes, maybe we need to clean up your gut a little bit, right?
Yes.
It's just your
Mhm.
immune system's engaged. So a comprehensive metabolic panel is going to tell us about how your kidneys are functioning, how your liver is functioning, if your blood sugar, again, it's a snapshot of your glucose. What you ate yesterday is really going to show up on a glucose, right? A fasting glucose. But again, it gives us an understanding, like if your glucose is at 120 and you're fasting, we want to go and check definitely an A1C because your blood sugar and how we manage that over a period of time is also going to be a risk factor for inflammation and oxidative stress in your body. So then we should always, 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 if we're going to treat with hormone replacement, I am a huge advocate that you have to be looking at the levels.
Mhm.
You have to look at the amount of estradiol, progesterone, your DHEA, your testosterone. And most importantly, too, is sex hormone binding globulin to see how much is actually being bioavailable in the body.
Yes, our body has a way, as you mentioned there, of protecting us by if we throw, for men, for example, real commonly they'll overdose on testosterone, or some doctors overdose people on thyroid medication. And our body has this mechanism of binding up all the excess so that we don't see as much free in those situations when we're getting too much. So you and I can look at that steroid hormone binding globulin and see, is there something playing in to cause a rise in this binding up of the free hormones? And then we may think about thyroid or think about estrogen or think about testosterone and what is the dose and is it appropriate?
And we may need to bring down inflammation in order to properly get them functioning with their hormones, their circulating hormones. So real quick, I know a lot of the population that listens to your podcast, Jill, has had mast cell issues.
Yeah.
So I want to throw out a case that I saw this morning. So this particular young woman she was 45. I consider she's young.
Yeah.
She's 45. She went down to, or she did telehealth with a practitioner down in Texas who's very well known as an influencer. And never did a lot of testing on her. They tested a few things and they put her on a 0.5 milligram, 0.05, sorry, estradiol patch. And when they went back to test, they didn't ask her what day of her cycle she was on. And when you put in the day of her cycle, she was really high. So, and the way that they tested it was on the first test was her first test for estradiol when they very first saw her was done on day 2 of her cycle. The next time they did it on day 19 of her cycle. Jill, do you want to explain the difference between day 2 and day 19 if you test estradiol in a woman that's cycling?
Yeah, so the first part is in follicular phase, kind of prime time, and that's where we have the dominance of estrogen. And then right in the middle, around day 14, it can vary with person to person. We ovulate. And if you would catch it on that exact ovulation, you would see astronomical 300, 400 levels. So it's this really high spike that allows the body in an ovulating woman to release that egg. And then you have the follicular phase, or sorry, follicular and luteal phase. And luteal phase is where we have progesterone then. So it's a cycle symphony. We have estrogen and then progesterone, estrogen, progesterone. And it's very common to have low luteal phase progesterone. So often we're checking hormones day 19 through 21. That's the standard. But comparing these two is like comparing apples to oranges, right?
Right. And what I want to bring up about that is she wasn't aware that she was being overtreated with her estradiol. So her number was really high in that luteal cycle. It was like 300 or something. It was really high. And with that, she had mast cell. She it triggered her mast cell. And she couldn't understand why in the last 9 months or since she had COVID actually, which COVID probably started this histamine reaction in her. But then it just never stopped after that. And that's because she was being overtreated with her estradiol, and that was triggering her mast cell activation. So she didn't know. Today I was like, we've got to change your dosage. And we also always have to test on the same day. That's why I brought this up too, is remember, if you're going to do this, be consistent about the day of your cycle. And if you don't know the day of your cycle, then you just want to do it around the same time of month that you did it before.
Yeah.
Just to kind of compare apples to apples.
I was going to say one clue that we've both seen a lot of. If someone has had a history of hormonal migraines, you better know what you're doing with hormone replacement because you can make them a lot worse.
Yes, you can. As somebody that survives hormonal headaches, migraines that are pretty severe, Jill, you know this about me. I've had to get to know this really, really well. And you do need to be very careful because you are a little bit more sensitive to that fibrinogen, that D-dimer. So that's another reason we want to know, are you even microclotting?
Yeah.
Maybe you have a CT scan, maybe you have an MRI, you have no signs of clotting, but then we test your fibrinogen and it's on the high end of normal, or your D-dimer is on the high end of normal or out of reference range, especially with these viruses these days. If we add too many hormones, guess what? We can aggravate that. We can make more clotting happen. So it's just a consideration. Again, context. We want to put your genes, your biological makeup into this pattern recognition that Dr. Carnahan and I use and see, are you at risk for certain things? And can we watch those to make sure we're not going down those roads? So I always look at ferritin and iron because some people, when they stop cycling, get really high in both ferritin and iron, which is a very oxidative state. And again, we want to pay attention to oxidative stress. We want to look at your thyroid and all of the thyroid labs. So I put TSH, free and total T3, T4, TPO, thyroglobulin antibodies. We want to look at it all because during this transitional time of hormone change, you can you can dip into an autoimmune.
Yeah.
I've seen it over and over again. It can happen right after pregnancy or during pregnancy. You can go from having an autoimmune during or before pregnancy, not have an autoimmune, and then it pops up a couple years after you have your baby. So it's just always good to watch those. Um, Again, watching LDH is a mitochondrial marker. It's called lactase dehydrogenase, and it's helping me understand a little bit about what's going into the Krebs cycle. Is that how you think about it,
Yeah.
Jill? And so it shows it's, and you can run ISO enzymes to kind of tell us where in your body could you be having some metabolic stress. So, for example, LDH isoenzyme 1 has to do with cardiovascular system. So I often check that if you've had COVID, just to see if your cardiovascular system is being stressed through a mitochondrial perspective. Anyway, getting back to glucose, I want to look at all aspects of how you're managing your blood sugar. So A1C is a 3-month look. A fasting insulin kind of tells me, are you having to pump a bunch of insulin out there because you're becoming more resistant? And a lot of people don't know this, but if their hemoglobin on their CBC was low, then guess what? Your hemoglobin A1C may be low because it's a hemoglobin A1C. And so your blood sugar may be your blood sugar may be look normal on your A1C, but it's all relative to how much hemoglobin you have,
Yeah. I
which
always
is an
use like frosted flakes. It's the frosting on the hemoglobin that's glycosylation creates this little layer. But ultimately, like you said, if you don't have enough hemoglobin, you could have a falsely low reading on A1C.
right. And so we've got to pick up on these individualized patterns. I look at homocysteine because that's a metabolic marker for the folate cycle, the methionine cycle, into transsulfation. So for me, it's a really important marker to say, okay, how well are you methylating? Because I don't run a lot of the expensive, like doctor's data has a methylation profile. I don't run that very often anymore. It's really hard because in order to run that correctly, it has to be put on ice right away, and a lot of times the tech doesn't do it correctly. And I've just learned that I pretty much rely on homocysteine and your CMV to give me a kind of a clear picture, and then symptomatically and other patterns help me understand how you're methylating. But homocysteine is really important for cardiovascular risk. It's really important for cancer risk. The higher that homocysteine is, you can be dipping into metabolic chronic diseases, and we want to keep you away from those, right, Jill?
Yes.
So, um, uh, did I say autoimmune, cancer, and it can even be impacting mood because
Yes.
homocysteine is you have to methylate really well. Oh, also for mast cell, even how you're managing mast cell
I break down
activation,
a histamine, right?
because in order to break down histamine, you have to have SAM, which is what's generated in the folate cycle, or I'm sorry, in the methylation cycle. So I also like to look at an NMR lipid profile because I want to know one of the benefits to HRT because it can help you lower your cholesterol.
Yes.
But if you have a lot of oxidized LDL and a lot of small particle LDL, Jill, we just had this discussion recently. This is what Jill and I do in our spare time. We love to talk science. So that's creating, that there's a lot of oxidative stress if they have a lot of small particle LDL or oxidized LDL. So it's another risk factor of, okay, what's oxidizing them? Is it their blood sugar that's not being controlled? Is it an infection? Is it a toxicity? What's causing that oxidative stress? Because we want to get ahead of it. Vitamin D is essential. That's another huge risk factor for if we're having a conversation, whether it's autoimmune or cancer. We don't want you low in vitamin D if we're going to avoid that. And that's 2 different ways to test vitamin D. We want to know if you are tripping into an autoimmune or have autoimmune activity. C-reactive protein and your SED rate or ESR is kind of telling us, do you have pretty systemic inflammation? So I think for the most part, we can talk about GI inflammation. It wouldn't set off a C-reactive protein or an ESR. But if you're starting a cancering process, if you're starting or you're flaring an autoimmune process, those are really high. And again, if you've got a high ANA, if you've got a C-reactive protein, if you've got a high SED rate, maybe not the best time in a flare to start hormones. Would
Mhm.
you agree, Jill?
Yeah, I would agree. And there's one caveat. Well, first of all, you also jaw necrosis or some sort of cavitation is one of those things that people don't think about because we're not dentists, but we
Mm-hmm.
both know the importance of
Mm-hmm.
is there something hidden in the jaw? One interesting thing I have found with autoimmune is testosterone can be, in the right circumstance, game changer for reversing autoimmunity. Again, in the right context, as we're talking, we're still going to do all the workup because women have multiple times the risk of men with autoimmunity. And one of the reasons is the testosterone levels. And I have found with some women, I use off-label testosterone to reverse autoimmunity. Again, in context, but that would be the one caveat where I think testosterone does help the autoimmune inflammation.
Awesome. I always love hearing your point of view. So selenium, copper, zinc, magnesium, knowing these nutrients, and we can run those on regular blood work for pretty inexpensive. So all of this should be covered under LabCorp or Quest or your local hospital. And your doctor should be able to run these pretty easily. Wouldn't you say, Jill? Like these are really easy labs that give a lot of information if we just run them all.
Agreed.
Now, I also think we absolutely, without a doubt, anyone that goes on hormone replacement, whether it's a man or a woman, should run a Dutch test,
Yes.
a full Dutch complete.
In
And
fact,
the
I
reason
require every year, if not every 6 months, anyone I have on hormone replacement, we do Dutch because it's so crucial, like you said.
And the reason why it's so crucial is this 4-hydroxy, right? Or 16-hydroxy. So we want to know what pathway you're taking through estrogen detox. And this is what gets missed by, I'd say, 99% of doctors that are practicing outside of functional medicine. They're not thinking about phase 1, phase 2, or phase 3 estrogen detox, which this is telling us, are you making a reactive oxygen species called quinolone, which is going to go and create oxidative stress and ultimately can mutate DNA. And the 4-hydroxy is the big kind of bad monster under the bed that we want to make sure isn't happening. So 16-hydroxy also promotes cellular tumors,
Mhm.
like just growth.
Yeah.
So more fibrocystic breasts and things like that, which can ultimately get inflamed enough and trigger into other things. So we want to watch, are you taking the healthy pathway 2-hydroxy? Are you taking a more naughty pathway 4-hydroxy? Or are you spending way too much time in 16-hydroxy? And here's another case study. I had a patient who went and saw another practitioner, got on hormones, ended up in my office saying, I don't feel well, but I know these hormones are supposed to be good for me. And her pie chart through the
Yeah.
Dutch test, if you was, I think she was 45% 4-hydroxy.
Oh my, I've never seen it that high. That's crazy.
It was really high. And so we had to rethink, okay, your genes, which we're going to get to next, there are genes that control the 2-hydroxy, the 4-hydroxy, the 16-hydroxy. There are genes that control the phase 2 estrogen detox pathway, which is called COMT, and how well you're methylating. That's phase 2. So we need to get we need access to this information. And Jill, I think Genova runs I think they run some of these markers, but my favorite is really Dutch for
Yeah,
both phase 1 and 2,
I would
as
agree.
well as looking at the cortisol curve and telling you your melatonin. Melatonin is breast protective, it's cell protective. If we're going to go and be exposed to a bunch of radiation, guess what protects you? Melatonin, fish oil, and magnesium. So whether it's EMF or whether it's radiation, for a mammogram or whatever, so we want to make sure you have the right amount of these things. And there's natural ways to up your melatonin, but somebody should be testing it. It's on that Dutch Complete or the Dutch Plus. So, um, I also think phase 3 estrogen detox, which is the beta glucuronidase, which is this bacteria that's naughty. And for some people, especially if you have constipation, but even if you don't have constipation, what can happen is you're taking estrogen, you're conjugating it, you took it through phase 1, you took it through phase 2, you dump it into the bowel to get rid of, and there's a bacteria that's naughty that unconjugates, unwraps the present that you were trying to get rid of, and it just reabsorbs back into you. And so we need to know all 3 phases of estrogen detox if you are going to be on hormone replacement. Would you agree?
100%. And interestingly, with mold-related illness, which is my little side thing that I love to talk about,
Mm-hmm.
glucuronidation is essential for every single mycotoxin detox, and that's a whole nother issue. But the important thing is this is crucial for detox, and especially we think of hormones as, oh, well, we make them, but what you're describing is the fact that we also have to get rid of them. And if we're not taking out the trash regularly, we need to know if you're taking out the trash, and if you're not, then you are at risk for having it almost act like a drug, right?
Well, and we're going to be, these metabolic markers are helping us understand, like, okay, how do we prevent things from happening in the future?
Yeah.
So genetic testing, from my point of view, I'm going to get into that next. That's what makes me a little bit special, is that this is something I can hang my hat on, and I understand pretty darn well, and I understand how these enzymes are working. So, but I'd love to teach more doctors about how just even the basics of the genetics that you need to be looking at, which they do see some of this activity on that Dutch,
Mhm.
that Dutch Plus or that Dutch Complete. So, the other thing you're going to hear me say is essential is environmental toxin testing, because we have to know what endocrine disruptors you have.
Yes.
This is a risk factor. Again, you may have no idea how much BPA, or that you have phthalates, or you have parabens, or you have atrazine that was really high, that are absolutely impacting your estrogen receptors. And so if we're going to add more to that conversation, we want to be detoxing you from what we know you have. And this is all individualized. So, one person that comes into my office is very different from the next, and their environmental toxin profile is going to look totally different. And if we were to speak to Jill's specialty here, and I see a lot of it too, is mycotoxins. They really mess up your hormones.
Really.
And we don't want to pour fuel of how this oxidative stress that mycotoxins cause take you down a metabolic pathway that you weren't even aware that was ignited by also the estradiol that you got put on, or the progesterone. So heavy metals, because again, and minerals, I think, are also important. Knowing that selenium, how much selenium do you have that is helping you with detoxification and managing oxidative stress. But heavy metals like mercury they act on estrogen, and they can create brain fog that you think is your hormone related. And really, we need to detox you of mercury.
Yeah, like
I
first
mean,
thing first, right? Like before you throw on a bunch of hormones, you really need to know the toxic load. You need to know the pathways. You need to know the genetics.
and go ahead. Sorry.
That's okay.
And then I say, again, if you want to understand how genetics are at play, I think an organic acid, but that's going to be an advanced practitioner. That's going to be somebody that's been doing functional medicine for a long time. It's not absolutely essential, but it is the next level to go to understand, how is the mitochondria getting beat up,
Mhm.
before we get into all this. So these are a lot of genes. You don't have to remember all of them. I'll say them out loud, but when I look at methylation, I don't just look at MTHFR. I look at what comes before it, what comes after it, what helps transport B12, how do you take the shortcut from homocysteine to methionine within this cycle? You need plenty of choline and betaine. So I'm looking at it from lots of gene perspectives and CBS. So there's MTHFD1, MTHFR, which lots of your viewers have probably heard about MTHFR. And I'm here to say it's a little bit more complicated than just MTHFR. So,
Yes.
okay, I'm going to get into a little bit of that because I just can't help myself. MTRR is more the B12, how you're moving through that redox part of your methylation cycle. And a lot of people don't understand, I'm going to show it to you, how many environmental toxins are actually influencing methylation more than your need for B12 or B9, which is folate. PEMT, TCN2, CBS. So this is a slide that I think most people need to see, but that's telling me about methylation. Then I'm going to look at like how well does estrogen, how well do you process estrogen? Do you have genes that are impacting your sex hormone binding globulin? Do you have ESR1 and 2 for a multitude of reasons? One of the At post-menopause, if you have ESR1 and 2, you're more prone to clot, just like having MTHFR, just like having there's several genes on here that I'm looking to see, okay, I really have to pay attention to fibrinogen and a D-dimer, as well as maybe phospholipids or antiphospholipid antibodies that could happen after a viral infection. CYP1B1 is that 4-hydroxy pathway. Do you have the genes that are going to speed that pathway up to encourage your body to go down that pathway? Whereas CYP1A1 is that 2-hydroxy pathway. So CYP2C1A, COMT, FUT2, CYP1A2 they all impact how you're breaking down estrogen. And let's just talk about COMT for a second. That's on the Dutch. But Jill, like, not only does COMT slow down estrogen from being detoxed from the body, what else does it slow down? That
So
enzyme.
I know this well because I'm a homozygous, double homozygous for this. Well, actually, I think one
Hmm.
of them I have two and one of them I have one. Either way, I have a lot of this activity. This allows us to break down estrogen and stress hormones much less rapidly. So for the people with COMT, they tend to show up in the world pretty driven, they do a lot. Because they're driven on norepinephrine and they're riding on those chemicals and they're not breaking them down. But the downside is this causes catabolism and breakdown of tissues and the stress effects on the human body probably quicker over time in those people because they can't break it down. I have a really quick funny story for you that will put this relevance. I remember maybe a couple years ago, I think I told you about this. I'm in the office and I had some sort of a mild allergic reaction. Well, we know quercetin is amazing for allergies and histamine, right? I grab my bottle of quercetin. I'm like, oh, 5 might be good. Or if one's good, 5's better. I take 5 of them. And an hour later, I'm driving home and I'm literally like shaking, like I'd been in a car accident. It's like, what is going on? I'm fried. Of course, I had just blocked the COMT pathway with that quercetin, and I was loaded with epinephrine, norepinephrine, almost like if I had just given myself a shot of adrenaline. And I knew firsthand the power of this COMT when it's not working, when you block it.
Well, I mean, and you had floods of dopamine as well, which
Yes.
is somewhat of a good hormone, but again, uh, this is an enzyme. COMT is an enzyme and it breaks down dopamine, norepinephrine, epinephrine, and estrogen. And so if it's slow, like Jill said, homozygous mutation means that it's already slow. And then you add certain nutrients on top of it, like quercetin. Guess what? You can cause PMS in a lot of people. You
Or
can
a
cause
panic attack, right? I've
or
never
or
had
a
panic,
panic
but that's what
attack.
it was like, what is going on?
Or heavy periods
For
or
sure.
fibroids over time, thinking that they're managing their histamine with a great immune modulating herb called or molecule called quercetin. But again, it has I think, Jill, what happens often in both naturopathic medicine and functional medicine is we get caught up in a metabolic pathway and we think, oh, this is what's going to help, just this pathway, and there's a bigger context.
Right.
And that's what this whole conversation today is about, is there's lots of context outside of just one area of you're looking at. Would you agree?
Absolutely. And years ago, this is like you said, PMS. For me, not knowing the power of quercetin and the connection, this is 20 years ago, I would get breast tenderness if I took too much. And that'd be a common like premenopausal symptom. And then postmenopausal, when the estrogen went like this, all of a sudden I didn't have those side effects with quercetin. So this is why the hormones matter, the age of the patient matters, the stage of the life cycle matters, and these nutrients and the genes, especially, which is your expertise.
Right? And how they're moving.
Yeah.
So again, I'll reiterate, these are all enzymes. So they're doing either a good job, meaning they're running either fast or slow, which just because you have a slow moving gene doesn't mean it's bad. It just means we may need to give it a little bit more support to move through, right? So if you have uh, a slow COMT on your Dutch, which is phase 2 estrogen detox, we might work on how do we get you to methylate a little bit better? How do we take out the things that might be influencing that bottleneck that happens in methylation? And then how do we also help COMT to move a little faster? And are you taking any supplements or nutrients that are slowing it down, as we just talked about? So, we also, I mean, I'm constantly looking at how well are you detoxing and what toxins are in you and what toxins are you going to have a hard time getting out and how do I influence these enzymes to work to your individual need. So, whether it's GST-M1 and the null gene, because most of us have the null, and how GSTP1, GSPX1, how are we recycling glutathione? And then how well is there's an enzyme right before you make glutathione, which is your master antioxidant. And I'm sorry if I'm speaking in lots of medical jargon, but this is your master antioxidant. It's so important to deal with oxidative stress and just cellular damage that our own body makes or stress makes in our body. This is our cleanup mechanism called glutathione, which is your master antioxidant. And Jill, if you have mold, that enzyme that goes to making glutathione from cysteine, it doesn't go. So then you run out of glutathione, right? So we need to know if you have that going on in your body, and you already have genes to predispose these enzymes working slower, and then you've got this glutathione deficiency. It's not about just replacing that. It's about getting these enzymes to work for you again. And 80%, just remember, 80% of your environment is more important than the 20% your genes are. So I didn't say that very well, but let me say it's more about the environment we put these genes into and the epigenetic factors that are making these enzymes either perform or underperform or overperform. And it's also the context of knowing what nutrients run those enzymes. And that's where I spend a lot of time with my patients. That's what I'm really good at.
You are like in the world that I know of. I mean, truly, you are such an expert. As you mentioned, that one thing that comes to mind is I think one of the worst mistakes you could make as a practitioner or as a patient is to start hormones when you have massive mold exposure. I think there's probably other more toxic situations, but in my mind, that's one of the most serious situations because that mold creates all kinds of alternate pathways and upregulation of aromatase. And so if you are in toxic mold and you're not yet detoxed, I will always wait to start a lot of new hormones on someone like that because, as you said, and this could go with any toxin, but because I deal with mold, it's really
Right.
particularly bad.
Any autoimmune flare, any mycotoxin, any really high environmental toxin load, be very careful about starting on hormones at that point. Clean that up before you even consider HRT, in my opinion. And that's what today is a big part, a big takeaway is just that.
Yes.
We need to clean things up to make sure that if we pour some good things, possible good things in, that they do good things. And so it's each individual needs different attention, right? And so you also have a tendency towards mitochondrial stress from the moment you're born with certain genes like CAT, SOD2, IL-6. If you have a lot of SNPs in these, you're prone to inflammation and you're prone to oxidative stress. And maybe you also have certain genes that make it so that you can't repair your DNA very well. And so these are all this is a larger picture again of how we're putting all these patterns and seeing what's revving up inflammation, what's creating oxidative stress, how do we individually help you? So this is the complexity of methylation, right? It's not just about MTHFR. And again, you don't have to understand the complexity of this slide. And thank you very much, Ben Lynch, for creating this slide and allowing me to use it all the time. He's really helped those of us that like to get into the nitty-gritty of helping with or understanding these cofactors, understanding what makes these genes go and slow down. I want to focus on this. This is the redox part of methylation. And again, it's not all about folate and B12. It's also about arsenic, cadmium, lead, mercury, acetaldehyde, which is produced by fungal overgrowth in your body, reactive oxygen species, peroxides, inflammation, and then if you have low B12 or glutathione, aluminum, or too much nitric oxide or too little nitric oxide, it's going to impact how these enzymes work. It's like a door that won't move. Like if you look at that, it's a circle, it's supposed to move, and it won't move if you've got a lot of burden in there, impacting that gene, or that enzyme, I should say. And look at what you need in order for MTR even to work is zinc, and MTRR, it needs SAM. You need to methylate well to begin with to make that go. You need riboflavin, and you need niacin. So B vitamins are really important for people, but again, we need to know what you need. And all this information can be found out. So the whole point of methylation, the whole point of it is to make this master methylator, who's a donor, to turn on and off genes or enzymes in the body. It's called SAMe. And you don't take SAMe. See, if you take SAMe, oftentimes you're going to end up causing a negative feedback where all of a sudden you don't think you need to methylate and you're going to slow down methylation. And you don't want to do that either. So you don't want to supplement SAMe. We don't do that anymore. But it's about being strategic about what you need in order to make your enzymes go and how well these pathways are moving. Anything to add to that, Jill?
No, but I just love that you brought this up because, like I said, we like to look at this for fun on the weekends. And the truth is, like, understanding these pathways really does give you a better outcome, and it may save you something very serious like a cancer diagnosis.
Right, because homocysteine is right here. And what I tell people all the time is if you have high homocysteine, it means that you're stalling out. You're not moving. You can't go this way, right? Because you've got something impeding your ability to move through MTR and MTRR, or there's not enough folate. But again, you can't go this way. You can't take the shortcut, and you're not going down through CBS. So you need some sleuthing. You need somebody to figure out why is that homocysteine pooling, and the higher that gets, the more the risk of cancer, the more the risk of autoimmune, the more that you risk cardiovascular disease. All of them have to do with homocysteine and how well you're methylating. And if you get the right practitioner that understands these metabolic pathways, your genes, what runs these genes, what inhibits these genes, what makes these genes go, again, fast and slow, it helps be very specific about what you need. And so Jill and I already talked about COMT. I just brought the slide in to show you, you have to methylate well, you have to have magnesium in order to make COMT go. But look what slows it down or speeds it up is infection. When you get a virus, when you have Lyme disease, when you have Epstein-Barr, all of these things also influence how not only you're feeling, like in your brain, your biopterin pathway, that's what we call it, and how you're managing dopamine to focus and concentrate, but it also influences how fast you break down estrogen. So I just had to throw up the definition of endocrine disruptors. I don't think people understand these chemicals can mimic, they can block, they can alter the effects of your natural hormones and your HRT, right? I think it's, again, we're going to get into a list, but phthalates, BPA, parabens, the PFASs, those forever chemicals, pesticides, herbicides. I gave you a little list here: phthalates, BPA, parabens. All of these act on hormone receptors. They're all creating havoc. And if we have no idea if you have mycotoxin, if we have no idea that you have mercury, if we have no idea that you have this atrazine or organophosphates, I still find DDT in people. Do you, Jill?
Absolutely. And again, this is very personal because I grew up on a farm with pesticides and atrazine and glyphosate, and I got cancer at 25, breast cancer, which is endocrine. Of course, my sister got thyroid cancer at 27. So, two girls in their 20s, endocrine related cancers. There's obviously a genetic and environmental impact there. And I remember like 5 or 6 years after looking up and saying, why in the world, besides, just genetics, did I get cancer at 25? And when I saw the map of atrazine and the usage in Illinois, it was a big aha. And that's just one of many. But this is important because it really, really has a toxic effect. And most of us are swimming in this toxic soup and we don't even know it.
And Jill, I'm so happy that you brought your case up. Do you believe that even though you had estrogen positive cancer, do you believe it was just your own hormones, or do you believe there was a lot, basically you're saying this, do you believe that there was a lot of environmental factors and genetics at play?
Yes, I would say probably 90% was environmental factors. And even as much as someone might be shocked to hear that I think in utero, I mean, this is not my mom's fault. She was in the same farm I was, but I believe
Right,
actually I started that toxic load in utero from my mother's womb.
right. So again, this is part of the individualized approach. This is a larger context to the conversation about HRT. If you have these endocrine disruptors, you have certain genetic SNPs, you have certain patterns on your labs, and then you have a big burden of endocrine disruptors that you had no idea of, then throwing hormones in could ignite a metabolic disaster. It's just the truth.
Yeah.
It's just the truth. So, infections, autoimmune disease, reproductive problems, metabolic disorders, all are from endocrine disruptors. And then we have to just touch on infections. So, infections also are going to mess with your hormones. Would you agree, Jill?
100%, yes.
Right? And these are some of them, right? Again, I mentioned EBV is associated with a lot of cancer activity. CMV is indicated in certain cancers. Tick-borne illness, mycotoxins, they can trigger you towards a cancering process. So again, if we can manage your oxidative stress, if we can treat any kind of illness or viral, bacterial, fungal overgrowth throughout your body, if we can manage your blood work so that your genes are working correctly, we bring up the nutritional deficiencies, we bring down the excesses that you might have. All of this equates to an individualized approach. So I want to sum up with mindset, because at any age, whether you have a pubescent child that's either a boy or a girl, and if you follow that all the way through life, we need to understand how we speak to ourselves, how our nervous system is functioning is directly influencing how our hormones are behaving. So I ask these questions. How do we speak to ourselves? How do we create rest in our lives and rejuvenation? How do we play? How do we reframe our experiences? How do we have a deeper sense of purpose that really brings excitement, and we offer ourselves in a larger context? And how do we focus on gratitude, which ultimately will bring joy? And these seem very simple questions, but they are deep and profound. And I ask everyone who is going through transition of their hormones at any age to ask these kind of questions. maybe not a teenager asks their deep sense of purpose. That's more as we change, as we grow older. But sense of purpose really carries our life force. It encourages our vis, which is our life force, to be bright in this world, no matter what's happening in this crazy world that we live in.
Shelese, I love that we're landing here because a couple comments. First of all, I think menopause for women is a great time to reevaluate relationships, purpose, meaning, work-life balance. I know you and I have gone through a lot of these things as we address our hormones and like, how do we live in our life? How do we have relationships? How much are we working? Because we love our work, right? But then if you're doing that too much, then is there an imbalance? And even personally, I'm like, okay, I want to shift and do some things. And I think I love the idea that all these hormonal transitions, and particularly right now, we're talking to women from 40 all the way to 65 and everything in between. It's a great time to think about this. And then the second thing I've thought of so often, and again, we so agree on this, is our body cannot heal or perform optimally if we feel unsafe. And so, whatever those things are that bring safety, and you and I share a deep faith in God and the power of prayer. And I just want to speak out to that because I think there's such power in even us getting together. People saw us in the coffee shop. Sometimes we're in tears and just praying together, just like, help us, God, help us with our work and how we show up in the world. But those are the kind of things, like those times with coffee with you are literally sometimes the times that sustain me for the next week. And I think getting together in community with other women, getting together in prayer meditation with other people in your community or whatever faith practice you have. I like to share mine because it's so powerful and I know we share that. And
Yes.
and then the meaning and purpose too is so critical. And menopause can be the best part of your life, especially because you have wisdom. And we talked about pattern recognition, right? And so pattern recognition only comes after you've had a lot of patterns to recognize. And it's another name for it could be wisdom because over time you start to see patterns. And you and I happen to be medical sleuths, but whether you are a homemaker or a teacher or any sort of area of work, when you hit menopause, you have the most wisdom and you continue to gain at that point. And I think it's actually so relevant that we talk about that because what are you going to do with that wisdom that God has given you? And this time in your life is a great time to reevaluate and say, where am I using my gifts to the best of my ability? And to really ask those questions. And sometimes the safety, the community, the prayer, the connection, those are the most powerful healers of any sort of supplement that we could give.
Absolutely. And and how do we play? How do we become playful again?
Yes.
Because age is not a number. And I just want to remind all of us out there to reframe. I'm 51 and a half. And again, how we talk to ourselves, how we reframe our experience of being not 20, not 30, not 40 anymore, being 50 and owning 50, but also being playful in 50 and finding newness and enjoying my life in a new context because certain parts of my life have shifted. I'm not doing the same things I was doing in my 30s. But it's an evolution and we're all in it and we're all called to be brighter lights in this world right now. And if I helped anyone be a little brighter today, that was my whole purpose, is to show you maybe places that you might need to dust off some labs, go look at it, and may look great. You may be in a great metabolic place, a great mitochondrial spot. And I just want to make sure that if something's not right, we find it. And I encourage you to have a full, beautiful life with sunshine like Jill's sweater.
I told Dr. Pratt here, I was like, I wore yellow for you because it reminds me, I don't wear yellow a lot, but today was a yellow day because the sunshine that you bring in everything that you do. Dr. Pratt and my friend Shelese, you are brilliant in the world, and it's such an honor for you to share your wisdom and many years of pattern recognition with the world. And I think people listening, they probably have a lot of questions. So if you're listening, hey, please put questions in the comments. Dr. Pratt and I will both be in here when it's live and answering your questions. And just know that there's hope. If you're out there, you're suffering in menopause, and there is a balance. So please find a doc, find a naturopath, find even a health coach if they really understand what they're doing or can work with a doctor, someone who can help you at this kind of level, especially if you're struggling, because it matters.
And if you have risk factors, like we talked about, there are more and more doctors that are learning this way. And hopefully, if you share this with your doctor, you can share this podcast with your doctor. Maybe they'll learn some of these metabolic pathways and help more and more people. That's our goal, right, Jill? Is that
That's
more and more people are served and that we create more individualized medicine and it reaches further than just you and I.
absolutely. I would say teach the teachers and influence the influencers, and we can make a tiny shift in that
That's
way,
right.
right?
That's
Where
right.
can people find your clinic and your Instagram? Give us a few places if people want to follow you or find you.
So my website is right here. It's theprattclinics.com. I think I'm Dr. Shelese Pratt, ND on Instagram. I don't post a lot. I'm not a big influencer out there. I just pop in and out when I feel like my expertise is being called upon. But I have a clinic here in Louisville, Colorado, right around the corner from Dr. Jill. And I am not I'm not taking new patients right now, but I send you to Dr. Carnahan's clinic. She has great PAs that work with her. Um, but I am happy to be a resource for people. And if I can't help you, I hope to find you somebody that will help you.
Oh, thank you. Thank you for your wisdom. Thank you for your time today. We're going to have part 3 and 4 because we've already had like part 1 and 2. So we'll get this to be continued, everyone. And thank you again, Dr. Pratt, for your wisdom.
Thank you. Thank you so much for having me.
Hey, everybody. Thank you so much for joining me for another amazing episode. Isn't Dr. Pratt amazing? She is one of the smartest people I know and a dear friend, as you heard in our podcast. I hope you enjoyed this episode. And hey, stay tuned because just after we stopped recording, we got together and we started talking about a masterclass, doing an online course, a masterclass going deep into genetics and physiology. And whether you're a physician or a coach or a mid-level practitioner or just someone who's really interested in the nuances of this kind of medicine, stay tuned because we will be putting out a masterclass in the next couple months, and you can sign up and be part of that. And I suspect we'll do more than one. So like I said, stay tuned. We will include a link in the show notes to sign up for my practitioner newsletter. That's the way you'll be notified. So if you want to be notified of a masterclass with Dr. Pratt and I, be sure and go down below the show here on YouTube. If you're listening somewhere else, jump on my YouTube channel. Just go to YouTube and Jill Carnahan MD. You'll find my channel, and this episode should be the latest if you're just listening to it. And then click on practitioner newsletter and subscribe. And we'll be sure and let you know when that is so you can sign up. Okay, guys, thanks again, and we'll see you next week for another episode of Resiliency Radio.